Intracerebral hemorrhage. It is the second most common form of stroke behind ischemic stroke. Most common causes include hypertension, amyloid angiopathy, and vascular malformations. There is a high associated mortality and morbidity, and as such, prognostication is important, though caregivers must be very cautious in early goal setting with families and patients. Here's an example of the perforating vasculature inside the brain. The most at-risk vessels are the small penetrating arteries, which become vulnerable over time to hypertension. Their morphology changes, putting them at risk for rupture. The volume of the bleed is an important component of various scoring systems practitioners use to prognosticate. The most common way of calculating volume is what's known as the ABC/2 method. In this example, the greatest width and length is 6 and 4 centimeters, and the height is 3 centimeters. When you use the ABC/2 method, it calculates a volume of 36 cc's of blood. Knowing the volume, as well as the clinical presentation, allows the caregiver to generate an ICH score. The ICH score is then used as a tool to help prognosticate. You can see here the elements include the GCS, the ICH volume, whether or not there is intraventricular hemorrhage, whether or not the origin of the bleed is infratentorial or not, and the age. Points are assigned based upon those elements. The GCS, during derivation of this scoring system, had the greatest impact, and as such, can achieve up to 2 points. When using the ICH score, one can predict 30-day mortality. You can see with each added point, the mortality increases. No one ever achieved a score of 6 because they did not see a combination of infratentorial bleed with intraventricular hemorrhage during the study. Again, this is a score used for a population-based approach to intracerebral hemorrhage that makes it very difficult to apply to an individual as they arrive in the neurocritical care unit. As such, it is very important you be careful in how you use the scoring system in talking to family members. When one has an intracerebral hemorrhage, what should the ideal blood pressure goal be? Here are guidelines from the American Heart Association, published in Stroke in 2015. You can see they say it is safe to lower blood pressure to 140 millimeters of mercury systolic. The practice here at Maine Medical Center is to target a systolic blood pressure of 140 to 160 when there's an intracerebral hemorrhage from a hypertensive cause. There is no role for routine seizure prophylaxis in patients with spontaneous intracerebral hemorrhage. And there is concern about untoward side effects of using anti-epileptic drugs in these patients. The first hours are critically important to avoid worsening and to give the patient the best chance for a meaningful outcome. Some of the possibilities include herniation, airway compromise, expansion of the hematoma, raised intracranial pressure, and ongoing brain injury. Early interventions to achieve the best chance for meaningful outcome include controlling blood pressure, correcting any coagulopathy, and whether or not a surgical intervention is warranted. This would be done in conjunction with our neurosurgical consultants. When controlling blood pressure, you want to use a rapidly titratable agent. Typical agents used are labetalol, IV push, nicardipine infusion, and clofidipine infusion. You want to avoid hydralazine and nitrates due to their role in causing worsening vasodilation in the cerebral arterial circulation. If one does have a coagulopathy, you should make efforts to correct the INR, especially if they're on a vitamin K antagonist. PCC, or prothrombin complex concentrate, is the fastest way to correct. And you can see a table here which gives some typical dosing to correct based upon the presenting INR. Here's a table outlining other agents to reverse medications impacting coagulation. For heparin, protamine, consider DD-AVP for antiplatelet agents. And then for factor Xa inhibitors, you can see some of the ways to reverse them here. There's also direction for dealing with direct thrombin inhibitors as well. As far as surgery goes, when one has a cerebellar bleed and it's above 3 centimeters, that is usually an indication for a surgical intervention to relieve pressure on the cerebellum, as it can compress the brainstem and lead to hydrocephalus. For lobar bleeds, it is a little bit more nuanced in terms of who requires a surgical intervention. It requires ongoing conversation with neurosurgery as well as the patient's family. It must be realized these surgeries for lobar bleeds tend to be more life-saving measures as opposed to impacting functional outcome. You may see the use of an external ventricular drain in patients with an intracerebral hemorrhage. This is to deal with hydrocephalus and typically goes in when you see these other parameters. There are characteristic ICP monitoring waveforms, as described here, P1, P2, and P3. And here's a sampling, again, of the different waveforms as seen when EVD is placed, what you'll see on the bedside monitor. An external ventricular drain setup looks like this. The EVD is placed in the lateral ventricle, and it drains to a collection system at the patient's bedside. It is important the system be level to the tragus, and the nurses are expert in doing this. Neurosurgery inserts the drains and will guide us on what level to set the system for enhancing drainage as needed. There is a guideline in the advanced practitioner's office for further recommendations regarding patients to consider for CT angiogram of the brain. It is derived from a combination of age, location, and other patient characteristics to determine who a CT angiogram is warranted for.